Good evening, everyone. This is Dr. Alish, MSH Pediatric Surgery Resident from Sion Hospital. Hereby welcome you all on the behalf of IAPS for this innovative IAPS NextGen lecture series. For today's talk, we have Dr. Pradnya Bendre ma'am. She's professor and head in Department of Pediatric Surgery at Bhai Jirbai Wade Hospital, Parel, Mumbai. She is an expert in the subject of urology, and hence we have been quite overwhelmed that she has accepted our invitation to talk on urology and the topic on PU valves. Also with us, we have Dr. Sanjay Ok sir, ex-professor and head and dean of various medical colleges in Mumbai. We welcome you, sir. With this, we would like to officially start the meet. Over to you, ma'am.
Thank you, thank you. Good evening,
কোথায়
sir.
ফোন তোমার ফোন
Uh,
কোথায় গিয়ে আমি অফ করবো?
I can see some disturbance, but let me start.
Ma'am,
Okay,
1 minute, ma'am, 1 minute. Also on
তোমার
today's
ওই
meet,
পাশে
we have
দেখ।
Dr. Sumitra Kumar Biswas, sir. He is the president of IAPS. Thank you, sir, for joining us today.
থ্যাংক ইউ।
Over to you, ma'am.
থ্যাংক
okay. Good evening, everyone. Um, so to start with posterior urethral, I assume this is basically for the postgraduates. So I will start with some hints for the exams. So posterior urethral wall is a very common scenario that we see on our practice, starting from the antenatal diagnosis, and it is frequently asked in the theory as well as it is a common case in practical exams. So just to give you the overview of what questions can be asked, these are the common questions that you will get in posterior urethral walls, starting from the antenatal diagnosis to gallbladder and different imaging modalities. So on every aspect of PU walls, there would be either short note or long question. Now one need to before starting any topic, we need to remember few names in that subject who has contributed significantly, and few of these names are Morgagni, Huge Hump, Young, you know. Devan is the another concept of posterior, that is copum, that is congenital obstructive posterior membrane. Glassberg must be remembered because he is the one who has told how the dynamics of the upper urinary tract and lower urinary tract are. Then Bloxham has.
Ma'am, I'm very sorry. I'm very sorry. Can everyone else mute your audio, please? All the participants here, so that ma'am can continue uninterrupted. Thank you.
Okay. Bloxham has contributed in creating vesicostomy. Mitchell is the one who described gallbladder. Peter is the one who has told the natural history, which is evolves into the gallbladder. And we cannot forget Indian contribution by Dr. Mohan Abraham. He has described valvotome and role of alpha blocker. Valvotome has been like good remedy for India, especially for the people who are working in periphery. And for me, when we never had neonatal scope, this was the magic which worked. And then Duckett, who described VURD, and Harrison's contribution in every fetal intervention. And cough is for the CIC and overnight drainage, which has made huge difference in contribution of the PU walls. So now little bit about the embryology. There are different theories that you must be going reading in your textbook, but every embryological insult will contribute to some pathological sequelae. So, besides simple obstruction of the PU wall causing obstructive uropathy is one simplified explanation for the whatever the effects of posterior third walls are. But besides that, this embryopathogenesis also explains why the taking away of the obstruction doesn't resolve all the features and all problems associated with the posterior urethral walls. And this is nice recent article which has explained everything. So these are the like embryological events, and this is the abnormality that results because of that embryological event. Mm, Now one must understand little bit of pathophysiology, why posterior walls progresses to renal failure. So this obstruction has impact on bladder. Obstruction has also impact on the kidney. So these are very well known concepts which have been described in your textbook, so we need not go in much detail, but there is a partial obstruction causing hypertrophy to compensate, and then hypertrophy increases the pressure and the cycle goes on, and at one point the mechanism of compensation gets decompensated and upper tract deteriorates. Another theory is because there is a high pressure, there are multiple factors, those are released, and there is a hypoxia, ischemia, reperfusion injury, and compensated mechanisms becomes decompensated, and progresses into the renal failure. This is the effect that is occurs at the kidney level. Initially there is a loss of nephron to compensate for it, is there is a hyperfiltration, then slowly it goes to decompensation, then glomerulosclerosis. The kidney loses the capacity of concentration, that is because of the effect on the tubules, because of the effect on glomerular filtration rate decreases. All these effects results in polyuria. Polyuria causes mechanical problems, and again the cycle goes on. So these two cycles happening at the bladder level and at the kidney level, we need to break, but many a times we are not able to break those cycles because it has gone to the stage of decompensation. The effects are irreversible, and as a clinician our job is to find out which stages can be broken, which cycle can be broken, at what stage we can break it to halt the progression of the renal disease. Now presentation, commonest presentation of the children would be incidental, rather antenatally diagnosed. In the current era of modern imaging, presentations are generally antenatal, but when they are not diagnosed antenatally, some patients still can present in older age group. And there is a recent statement which has come from the BAPS. There is an article which has published in 2024 which says that in spite of advanced science, there is a quite significant number of patients who are presenting in older age, though imaging is advanced. Now, to discuss the management of posterior urethral wall, we will be dividing into few basic categories. One is antenatal diagnosis at 18 to 24 weeks, then in a last trimester diagnosis, and then patient is delivered, which is stable. Another scenario is antenatally diagnosed but unstable child, and then older children. So let us go with the scenario number one, which is not uncommon, especially in a tertiary care center where we are getting referrals in an antenatal age group with more and more training of the obstetricians in anomaly scan. These anomalies are picked up quite early. So at around 18 weeks also you can pick up the posterior urethral. What you see is generally dilatations, hydronephrouretrosis, and keyhole appearance. So when they come to us, what do we advise them? So what sonographic features they have described, we need to correlate whether those are significant or not significant, because it may not be the only diagnosis. Posterior urethral, you have to reach to the diagnosis of posterior urethral wall. So hydronephrouretrosis, then you immediately need to ask about the what is the status of bladder, what is the status of the fluid, how are the kidneys, and based on that we would generally come to conclusion whether it is posterior urethral walls, and what type of posterior urethral walls, means whether it is a severe bad prognosis posterior urethral walls or it is a good prognosis posterior urethral wall. It is very important to know the differential diagnosis. So the moment we see hydronephrouretrosis, with abnormal bladder, we should tell obstetrician to do specify about the spine, because spinal dysraphism can mimic the picture of posterior urethral wall, and that would be commoner anomaly which we are coming across. So if it is not neurogenic bladder, then our closest diagnosis is posterior urethral wall. So keyhole appearance should not be misguiding, though it is commonest finding in the posterior urethral wall. But these are other conditions where keyhole sign can be seen, but still it is very significant finding that will tell you that it is posterior urethral wall. So when you are counseling the parents, you must know the natural history of posterior urethral wall. We know that 50% of the posterior urethral wall goes in chronic renal failure. Significant number of patients would develop end stage renal disease, and our job based on the ultrasound which is provided to us is to find which children, which findings of poor prognosis are present in that ultrasound, whether it is a bad prognosis posterior urethral wall. This is very important to know, because when patient is referred at 18 to 20 week, they have an option of termination. So when do we advise termination? So for advising termination of pregnancy, it is very important that you are not relying on one single anomaly scan. We must ask for one more opinion by the level 2 radiologist, and have every detail, and having seen getting the same findings, we must counsel the parents, preferably by the team of obstetrician, nephrologist, and pediatric urologist, and then give the option of termination. Generally, termination of pregnancy option is not given by pediatric surgeon, but we just suggest them that this child is likely to go in renal failure in first 2 decade of life. He may require, if we see severe oligohydramnios, he may require ventilatory support, and the outcome of these children is not good. And then a decision of termination of pregnancy is left to them. In India, the MTP law has been changed, and even if pregnancy has progressed beyond 20 week, up to 24-week, once we follow the legal procedure, termination can be advised. But decision of termination is very tricky, and it should not be taken by single pediatric surgeon. So, less than 20 to 24 week counseling about the renal and bladder outcome, you have an option of termination or a continuation of the pregnancy. If they continue the pregnancy, then we reach to the second scenario. And this is the scenario where we are seeing patient beyond 24 weeks entering into the third trimester. They should be very closely followed up. Then the next debatable questions and options that we can tell them and parents would ask you is, late in pregnancy, how is the child's renal tracts are they developing normally, are there any secondary effects, what is going to happen to my baby after delivery, is there any intervention that can be done in utero. So once patient comes in beyond 24 weeks, the challenge for pediatric surgeon is to decide whether they require any antenatal intervention. And antenatal intervention are not too early, not too late. So and it is very important that if you are planning intrauterine intervention, you have to be very very careful and sure that your intervention will benefit the child. There are lots of side effects on the baby, on the mother, and that is why we must assure and we must be sure that your intervention will give some benefit to the baby and will not harm the mother, and that's a very difficult task. So there are some values which have been told about the fetal urine, which will tell you that predicts the good renal function. So what are the fetal intervention? Those can be done. Psychoamniotic shunts, fetoscopic ablation of the walls. And then there are two trials which have done about this. One is the Pluto trial, where percutaneous intervention for fetal lower urinary tract obstruction has been done. A RAF trial is to increase the amniotic fluid so that there is no pulmonary hypoplasia, so that secondary effects are taken care of. But currently, fetal surgery has a very limited role. Few high risk fetuses in utero may die because of the severe oligohydramnios if they have normal karyotype, and there is a evidence that there is a reversible function. In those cases, fetal intervention may be given, but I would not hesitate to say that it is more of a theoretical option, and there is no consensus on efficacy of use of prenatal intervention. Recently in 2024, review article has been published from the Michael Harrison, who is father of fetal medicine, and this article has given long term follow up of the patients who have been intervened, and there is no significant difference in renal outcome. So transiently maybe you get some amount of improvement, but if you look at the long term outcomes, then their renal salvage rate is not improved after the fetal intervention. So it is more of a theoretical interest rather than practical interest. I know that we have one center in India, and Dr. Mohan Abraham is doing fetal intervention, but I would say that indications are very limited. So then we come to the next scenario, that child was antenatally diagnosed and is about to delivery. The most important advice we give to this patient who has crossed second trimester and close to third trimester, as first important thing is they should get delivered in a tertiary care center where all the facilities are available. The presence of oligohydramnias tells you that child can have respiratory distress after the delivery, and your ventilation, neonatal care should be kept ready. And actually, in a tertiary care center like us, we form a prenatal team where all these specialists see the patient together, so that baby is delivered, neonatologist is available, ventilator is available, pediatric surgeon is also available. So if patient is stable, you have good time to evaluate. There is no hurry in reaching to the diagnosis. First and foremost is you have to confirm the diagnosis that it is posterior third wall. First thing I would do is we will find out whether it is boy or girl. If it is girl, your suspicion of PU wall is ruled out. If it is a boy, child looks stable, active, pink, no respiratory distress, then we patiently wait for child to pass the urine. Unless and until there are abdominal findings which are suggestive of hypertrophied thick bladder or child is in a retention, there is no hurry. So stable child after delivery, you have two options: either catheterize or don't catheterize. Many children, normal children also don't pass urine in first 24 hours, so you have to be very patient. None of the serum chemistry or creatinine values are useful in first 24 hours, because those would be reflecting on maternal value. So you have to patiently wait, keep a watch on them, and then decide whether it is a posterior urethral wall. So what you need is simple urine analysis, serum chemistry. These are done after 24 hours. Ultrasound can be done in within 24 hours, and that will definitely give you good diagnosis. But gold standard for diagnosis is voiding cystourethropy. Neonatal catheterizations are tricky. Chances of catheter associated infections are there. So many centers do VCUG in OT and proceed further for the whatever procedures are required. So if after 48 hours, if serum creatinine is in an acceptable range, urine analysis is normal, I would rather, and sonography is confirming that it is posterior lateral wall, I would rather do the VCUG in operation theater. For the corporate centers where hi-fi facilities are available, they can do VCUG before posting the child for surgery, and then take a call about the diagnosis. Having done VCUG and confirm the diagnosis, the stable children, you have a option of therapeutic procedure by primary fulguration, and then they can undergo diagnostic cystoscopy. So what do you see on imaging in suspected posterior lateral wall? You start from the top, start from the, either start from the kidneys or start from the urethra, but go in a systematic manner and check every possible detail on ultrasound. Good ultrasound gives you lot of information as a baseline as well as for the follow-up. So we check for the parenchymal thickness at middle, low and upper pole. We check for the parenchymal cyst, corticomedullary differentiation and echogenicity. These three findings tells you that probably child has a dysplasia, and these are not the good kidneys, and these are the irreversible changes. Rest all measurements are also very important, because baseline investigations and the outcome of surgery can be compared, and you would come to know whether a simple fulguration is sufficient or you need to do something else. Posterior and anterior urethral diameter, there is a study by our own Indian center, KM Hospital, and the ratio of anterior and posterior urethral diameter can tell you that it is posterior urethral wall. That will also help you for the post-operative outcome of the fulguration. Sonography of the kidney, this is just for the reference I have mentioned, but majority of the people do not give such details. But it is very important to know the renal growth, because the first year is the maximum growth of the kidney. Kidney grows by 1 to 2 millimeter every month, and that is why whatever the interventions we are doing, those are very important, because we are doing it in a fastest growing time. This is about the ratio. Now, these are the standard guidelines given by Indian Association of Pediatric Surgeons. So, in a consensus statement, so I will not go in detail of these guidelines. You can just read the consensus statement, where every final detail about how much urographin should be given, what should be the rate, everything is given. You can go through that. Then come to the fulguration. As far as fulguration are concerned, when you start talking about the fulguration, lot of questions come in the exam and in practice also. Then there are multiple modalities by which we can do a wall ablation. The basically wall ablation will be done at 5 o'clock, 7 o'clock, 12 o'clock position. You can use either hook, you can use either bugby electrode, you can use cold knife. But this is the appearance of walls that you see. Commonest is the type 1. So you first visualize the value. As you come out, you will see the folds going on both direction. And if it is hook, you will be able to engage the wall. So 5 o'clock, 7 o'clock and 12 o'clock fulguration. When you are doing 12 o'clock fulguration, you have to rotate cystoscope by 180 degree and do the fulguration at 12 o'clock. And this is the appearance after the fulguration. You can see increase in the size of lumen. On table, you can just press the bladder and watch for the stream. So these are the standard operating guidelines for the cystoscopy. Again, I am going to quickly run through these slides, skipping the slides. It is given in consensus statement by JIAPS. We must learn how to calculate GFR, because serum creatinine and all other biomedical parameters are quite crude indicators. We must be very sensitive about knowing the GFR and whether it is increasing or not. It will be very important to involve nephrologists from the beginning, pediatric nephrologists from the beginning, and have discussions together to know the outcome of the fulguration. Radionuclide scans are done at follow-up period. Generally, one baseline scan is obtained. One is DMSA if there is VUR, and MAC3. MAC3 will tell you the excretory function, and DMSA will tell you about the parenchyma. This is very crowded slide, but you can take a pic because every detail about both the scans is given in this slide, and these are the commoner questions that would be asked. What is the difference between MAC3 and DTPA? Why you want to prefer MAC3 or EC scan or DTPA? Given an option for excretory function dynamics, for the parenchyma it is the DMSA, but for the dynamics, that is from the flow of urine from kidney up to the urethra, MAC3 is best because that gives best image qualities. The reasons are mentioned over here. After MAC3 is the EC scan, and DTPA is last on the list as far as excretory function is concerned. But unfortunately, MAC3 is not available in India. Very rarely it is available. Advantage of MAC3 is you can do scan as early as third week post of life. Having completed the treatment and when child is ready to go home, we must know what advice we are giving. When do you want to do the follow-up investigation? How do you know the adequacy of fulguration? And this is the protocol which we have borrowed from GOS. Here again you need to remember that every 3 monthly you need to see for the ultrasound. VCUG is done as and when required. So you can follow up the patient by ultrasound, and if ultrasound is showing you improvement, dilatation is coming down, bladder wall thickness has gone down, if they have visualized the posterior urethra as the beginning and posterior urethral diameter has gone down, then probably there is no need of repeating the VCUG. The commonest question that would be asked in exam: having done the fulguration, what do you want to do next? When are you going to call the patient back? Are you going to do VCUG? Are you not going to do VCUG, or directly you are going for chexcopy? So the protocol would vary institute wise. For us, we do the ultrasound. We ask for the history. If baby is passing urine in a good stream, we tell every child to come back with the video of micturition if possible, and if video is showing good stream without abdominal straining and child is growing well, there is no UTI, ultrasound is showing improving parameters, then we assume that our fulguration was adequate. Few centers will not rely on these picture, and they will ask for the VCAG. Few people go directly for the chexcopy. So the option is yours. You have three options: assess clinically and ultrasound wise, assess by MCU, assessed by chexcopy. Whatever the your institute prefers and whatever the way you are proficient, you should adopt to that, but vigilance is required. Now coming to the second scenario, fourth scenario, the patients are antenatally diagnosed, delivered, but they are unstable. What do you mean by unstable? These are the all things that can happen to the children who have bad kidneys and bad tracts. There can be respiratory distress because of the pulmonary hypoplasia, which is occurring secondary to oligohydramnios. There can be severe acidosis. There can be hyperkalemia, which is very hazardous. There can be hyponatremia, hypocalcemia. There can be uremia. Commonly, we observe them by the serum creatinine levels, and there can be less urine output, and soon they can develop urinary tract infection, and there can be hypotension. So, all the children who are not stable, they may require whatever based on the clinical assessment. So if there is a distress, they may require ventilation. The children who require ventilation are the extreme because they have resultant pulmonary hypoplasia. So their outcomes are guarded, and these are the patients who are very difficult to stabilize. So generally, initial stabilization will consist of catheterization. You drain the bladder, you do the metabolic stabilization, correct the acidosis. If there is hyperkalemia, correct the hyperkalemia. If there is no UTI, start the prophylactic treatment and watch for the diuresis. If after catheterization there is a diuresis, that's a good sign because that is telling you that kidney has potential to recover. And for first few days, you follow all these things and see if patient is improving or not improving. If patient becomes stable, then the first choice of most of the pediatric urologists is do primary fulguration and then send the patient home for the follow-up. If they are still unstable, then here is a debate. Then the questions would be, do you want to do fulguration and wait and watch, or do you want to do diversion? This is just about the management of the post-op diuresis, wall ablation. And then coming to the most debatable topic, that neonate after 4 or 5 days or even 1 week of catheterization, if creatinine is not coming down, child is hypertensive, child is not showing diuresis, and ultrasound is showing hydronephroureterosis, dilated tortuous ureter, thick wall bladder, is diversion going to help? So different options in diversion are vesicostomy, refluxing ureterostomy, end ureterostomy, Y ureterostomy, ring ureterostomy, and multiple options of diversion are there. So first and foremost, I will tell you that majority of the pediatric urologists will not agree for the diversion only based on the high creatinine. But along with the creatinine, because child is catheterized, tracts are not draining, there is a oliguria. Child may develop urosepsis, and if urosepsis is there and your ultrasound is showing that echoes are there even in kidney, that means infection has reached to the kidney. We are not able to clear it with the catheterization, with the medical management, changing antibiotic, giving fluids, then that will be unequivocal indication for diversion. Getting rid of infection in an obstructed system is extremely difficult, especially one of the kidneys is less functioning or non-functioning. It is next to impossible to get rid of the infection. There the option of diversion is unequivocal. Second incidence where everyone is agree with the diversion is premature children. With the advanced neonatal care, premature care, we are seeing many prematures, and the tiny babies less than 1 kg, 1.5 kg, where scope cannot go there. Also, it is generally accepted that vasectomy should be done. So, undoubted indication for diversion in posterior urethral wall is vasectomy for premature children where scopes are not available, and uncontrolled urosepsis where we are not able to get rid of infection. But for raised creatinine, most of the studies has shown that on long run it doesn't make any difference. So having said that diversion is a debatable thing, then next question is when to divert and where to divert. um, Again, the level of diversion is also debatable, whether it should be high diversion, high ureterostomy, which side of the kidney should be ureter should be diverted, whether it should be vesicostomy, whether it is PCN. Then so all these things, decision has to be taken. Then how do we decide the level of diversion? You have to have thorough study of the ultrasound, avoiding cystourethropy. If scan is available, then scan, because scan will tell you which kidney is better functioning kidney. It has happened a few times that in neonatal age group we had to divert, and we diverted on the only functioning kidney, and the bladder and opposite system was completely dry. We do not want that incidence also. So it is important to judge the function of kidney, which can be done on ultrasound also. Parenchymal thickness, echogenicity, presence of cyst, all these things are going to tell you about the function. And then you have to see for the ureteral dilatation. More dilated the ureter, more suitable that side for the diversion is. Then presence of internal echoes. If one side is showing internal echoes, other side is relatively clear, then we prefer to divert on the side of the affected side. Presence of reflux. If there is a reflux on one side, refluxing ureterostomy is quite popular, because that will not only drain the ipsilateral kidney, that will drain the contralateral kidney also, and that will maintain the bladder cycling also. So the debate about the diversion, that we are making bladder unused bladder, we are making bladder dry bladder where further fulgurations are not possible, refluxing ureterostomy looks like a better option in all those scenarios, taking care of all the problems. And then the capacity of bladder and bladder wall thickness. The moment someone asks you, do you want to divert, immediately the residents gives answer, yes, I want to do vesicostomy. And then I will show you the picture. If this is the MCU picture, and if this is the bladder, technically doing vesicostomy is impossible. So vesicostomy option, level of diversion should be decided after thorough study. If this is the scenario, and refluxing ureterostomy will be the better option. If this is the scenario, then vesicostomy may be the better one. Here it is always tricky. Sometimes unilateral ureterostomy doesn't work. Sometimes this is a small bladder. So vesicostomy is a challenging job. But if you have to decide no whether your diversion is helping, Glassberg has described the types of ureters, and these types of ureters would be emptying with the full bladder or empty bladder. In that case only fulguration can be sufficient. Ureters which are emptying with the bladder, empty bladder, but not with the full bladder, in that case vesicostomy may be beneficial. Ureters not emptying in spite of the empty bladder. If ureters are not emptying in spite of the empty bladder, that means there is obstruction somewhere at the UV junction, and your vesicostomy may not help. So great discussion, great study is required to take the decision of diversion. But having done the diversion, generally we are able to get rid of infection, and children are ready for the discharge very soon. Now, having said that, now children are ready for the discharge, what medications we should put them on? So multiple medication, and every single medication is going to be the topic of discussion in the exam as well as in real life scenario. Whether to give alpha blocker, what is the role of anticholinergic, there are newer drugs like mirabegron, sulfenacin, what is the role of these newer medication. If we see seeing the poor prognosis, advanced renal failures, do we start them on ACE inhibitors? Our nephrology generally prefer ACE inhibitors to delay the transplants. And besides that, there are supplemental things that helps, that is low protein diet. Then we have to tell them how frequently we have to do ultrasound. 70 to 80% of growth of kidney happens in first year. So if you are seeing the neonate, it is prudent to advise them every 3 monthly ultrasound in first year, and later on everything is stabilized, you can make it 6 monthly ultrasound or annual ultrasound. Checkscopy, I already told you, is institution preference. They want to go ahead with the checkscopy. People do checkscopy anywhere from 4 weeks to 6 weeks. VCUG, the people who want to do VCUG post fulguration, they generally do after 4 weeks. The scans are done at after 3 or 4 months of life. Then you have to keep somatic growth record, renal growth record. We are, as a surgeons, we are not used to keeping renal growth record, but there are nice nomograms for the renal growth. There are nice renal growth charts which can tell you how the growth of kidneys is. You need to sit with your nephrologist, team up with the nephrologist and understand nephrology of PU walls to have a best outcome. As child grows, time voiding is very important. For the patients who are not getting stabilized, there is undoubted role of clean intermittent catheterization and nocturnal bladder management that will come up. Yes. So we must know what are the effects of obstructive uropathy, and you have to follow up the children for all these factors. Now, what are the principles of this follow-up? Generally, to every PU all patient, when they undergo fulguration, we explain parents that this is not the end of treatment. This is the beginning of the treatment, and treatment goes lifelong. As they become 18-year-old, they come out of purview of the pediatric surgeons. There has to be proper transition, and every child should be handed over properly to the adult nephrologist and urologist. And we must remember that these are our goals. We want to maximize the renal function, and whatever as a clinician we can do for maximizing the renal function, we should do. Minimize urinary tract infection. There are multiple ways to minimize urinary tract infection. Simple things we tell parents is do not use diapers. They never know when the child is getting soiled with the fecal matter. If they are, we have put them on chemoprophylaxis. Generally we give sandwich therapy so that resistance is not developed. Intermittently we are giving probiotics so that there is no tolerance to the antibiotics. Then minimizing scarring would be secondary to the minimizing urinary tract infection. Assess the bladder growth, and watch for the urinary stream. Bladder growth can be assessed either by ultrasound or by the VCOG. As child grows, it is very important to have detailed voiding history and questionnaire of lower urinary tract dysfunction, because initially improving child can suddenly start showing deterioration. And when child starts deterioration, we must find out if there is any voiding dysfunction that is setting in, or there is any stricture infravesical obstruction that is again setting in. And then we need to find out what is the need for renal replacement therapy to these patients, and is there any, are they going close to the renal transplant. If we are very careful, very prudent, and if the kidneys and tracts are improving, we can keep renal transplant as away as third, fourth decade. So goal of even in poor prognosis PUL would be delay renal transplants as much as possible. But you need to remember one thing is that do not compromise bladder for the kidney. Kidney can be transplanted, but bladder not. This is said especially for the vesicostomies, because there is a debate that vesicostomy will alter the function of bladder. So if the people who believe that bladder function gets affected by the vesicostomy, they would not do vesicostomy, because bladder gets utmost care. I would change the chemoprophylaxis, I would change the anticholinergics, may add alpha blockers if I want the bladder in a best condition. This we already talked about. Again, this is the protocol for follow from the Indian consensus statement. Diet cannot be underrated. It is very important, especially in an era where Indians are also adopting the Western diet. Kids are very used to having one packet of chips. If you ask mother, they say normal diet, but one or two packet of chips. So remember that papad, pickle, chips, they have humongous amount of salt. So if you want to keep low salt, you have to tell them that these Children should not develop these habits. So papad, pickle, chips, cold drinks should be avoided in these patients. Salt should be as low as possible, and the protein should be modest. We don't advise them 3 gram per kg, but up to 1 gram per kg may be permissible. Protein directly increases the glomerulofiltration rate 3 times, and as the glomerulofiltration rate increases, the vicious cycle which I described initially will set in, and they will go in glomerulosclerosis early. That means they are going close to the transplantation. Water intake should also be limited, and there is a then coming to the prevention of infection. The children come to us in a neonatal age group, they may require antibiotic up to their rest of the life. So you have to be very careful about escalating antibiotic, about giving them chemoprophylaxis. Remember that for several years they have to take the antibiotic. So safest antibiotics in neonatal and infancy is amoxicillin. Clavulanic acid combination should be avoided as far as possible because that gives resistance very quickly. Cephalosporins, nitrofurantoin is a very good chemoprophylactic agent, but that is not palatable. Septran, that is trimethoprim sulfamethoxazole, can be given after 2 months of the age. But we prefer to give sandwich therapy for a couple of months, amoxicillin, then cephalosporin, and that way the resistance would be less. And now, what would be the timing of giving chemoprophylaxis? Generally, we say either OD or HS. HS is before going to bed. So the children who are toilet trained, who retain urine throughout the night, it is best to give chemoprophylaxis in the night, because urine will be stagnated for the longest time. But the infants who are passing 24 hours in a cyclical manner, the dose is OD. So for every single thing, there is a rational OD dose in a children who are not toilet trained. Once they are toilet trained and they are dry in the night, you have to give chemoprophylaxis in the night. This is the mechanism of action of different drugs. Again, I'm not going in detail of this, but yes, there will be multiple questions and debates about whether to give alpha blockers or give only anticholinergics. How do we give anticholinergics? It is again institute wise protocol, but whenever we are seeing that bladder is thick walled, we assume that it is a very less compliant and rigid bladder, and we give anticholinergic. So in our institute, at least, we are depending on the ultrasound findings, because we are not doing UDS in neonatal or infancy. If we are seeing thick walled bladder, that is more than 3 millimeter diameter thickness, and there is a VUR and thick severely dilated ureters, we put them on anticholinergics. Alpha blockers, again, few people agree with that, few people don't agree. But if you are giving alpha blocker, that is expected to reduce post void residue, and is expected to help the bladder by going into vicious cycle of decompensation. Bladder neck incision is also done, but that has a limited role. And this is the mechanism of oxybutynin. There are other agents which can be given, and I think it is common practice to start oxybutynin. The only question is when to stop oxybutynin. I think those questions are still not answered. So they go on oxybutynin for several years till we see the tracks which are normalized. A role of alpha blocker, again, relaxation of the bladder base and proximal urethral sphincter resistance is reduced. Bladder neck incision, few people strongly advocate that, but you need to be very careful. bladder neck incision can cause urinary incontinence. It can destroy sphincter. So one has to be very careful about the bladder neck incision. So far, I have no experience of bladder neck incision, but that is a theoretical thing. This is the renal growth chart, which I wanted to just show you. Then normal growth, you must know what are the different stages of end stage renal disease, because up to this stage it is reversible. So whatever the, if you are seeing progression towards stage 3 and then stage 3B, you need to aggravate your efforts. You need to be more aggressive, more sensitive in taking them back to stage 2 or stage 1, because these are the reversible stage. When they go to the stage 4 and stage 5, then majority of the role of pediatric urologist is stabilization of the bladder and delay transplant as much as possible. So the moment child has gone in stage 4 5, the question pediatric urologist has to answer is bladder stable, is there VUR, is there any role of augmentation cystoplasty, is it going to delay the transplant, and each child going to need transplant in a near future. Now the another topic of discussion is UDS in posterolateral wall. So when do we do UDS? UDS is a very invasive test. Kids are not cooperative. PU all has sensate urethra, so it is extremely difficult to do urodynamics in posterolateral wall. But anytime when you have ruled out that there is no infravesical obstruction, the recovery is not up to the mark, means even 4 years after the fulguration, MC is showing good urethra, but hydronephroureterosis is not going down, then probably we need to find out the bladder dynamics. If there is incontinence in spite of attempts of toilet training, and there is a persistent reflux, then that may be indication for the urodynamics. Again, if there is a VUR and sensitive urethra, it is very tricky to do urodynamics and very difficult to interpret urodynamics. So for the children who where we have diverted, next question on follow-up is, when do we do undiversion? So generally, as I said, maximum growth of the kidney occurs in 2 years, first 1 or 2 years of life. So if you have diverted, you might leave the diversion for first 2 years, because kidney can have maximal chance of the recovery. But beyond that, there is a doubtful role of keeping that diversion. And as children grow, they start playing with other kids, they start going to the school. It is very important to reduce the psychological impact on them, to provide them dryness. So by 2 years they should be, we should consider about the undiversion. And when we are doing undiversion, it is very important that there is a very efficient method of bladder emptying. Either it is low pressure voiding by spontaneous voiding. If lower tracts are clear, urethra is clear, bladder is good, it will be low pressure voiding. If that is not achievable, then you can start them on intermittent catheterization. But bladder dynamics, bladder pressure has to be kept optimal, and bladder should be stabilized before undiversion. Otherwise, the changes of obstructive uropathy in kidney is going to get aggravated. Now, another topic of discussion and lots of debate is VUR and posterior wall. Vesico-ureteric reflux is expected to disappear. It disappears in more than 50% of the patient. If fulguration is adequate, bladder is stabilized. But if it is, there are few incidences like almost 40-50% VUR is not disappearing, then what should be done? Whether it is nephrectomy that we have to offer or reimplantation, and what is. But for the patients where VUR is not disappearing, they are the poor prognosis children. They go to the end stage renal disease generally in second decade of their life. So VURD syndrome, again, it is a topic of short note. introduced by the decade who assumed that it is a pop-up wall. Initially, it was thought as a pop-up wall, and that is why the opposite kidney is preserved. But that sounds to be very simplistic, and there are multiple embryopathological explanation why there is a non-functioning kidney on the side of severe reflux. It may not be only because of the pop-up, but yes, temporarily, transiently, it takes care of the high pressure. So opposite kidney is saved at least for some time. So unilateral reflux may be protective and may be beneficial on long-term renal function, but this second statement is again debatable. So when VUR doesn't resolve, if it is a poorly functioning kidney, generally the reflux doesn't disappear. And if it is associated with bladder dysfunction, so in spite of adequate wall ablation, VUR is not disappearing, then you need to find out about the bladder. And if VUR is not gone, not regress, and if it is becoming troublesome, then you need to tackle it. So if there is a recurrent urinary tract infection, there is an incontinence, bladder is going into the wall bladder because of the yo-yo movement and persistent residue in the bladder, then reimplantation or something else can be considered, but re-evaluate the child again, find out how the bladder function is, and then decide whether reimplantation can be done or not done. The outcome of reimplantation would be close to the reimplantation in primary VUR, provided bladder is stabilized perfectly, which is almost impossible. So especially in our institute, we have made a protocol whenever we are requiring reimplantation in cases of posterior urethral walls, we are adding metrophenol and CIC and overnight drainage so that reflux does not disappear. It is not possible to continuously monitor the bladder. So adding metrophenol and CIC would be beneficial if we are reimplanting them. In the era when deflux was available, majority of the people preferred deflux for the treatment of reflux, but that was more successful in lower grade of refluxes, and grade 4 5 with wide orifices deflux had limited role. Another problem in posterior wall is some children come back with incontinence again and again. The reasons would be residual wall, sphincter injuries, bladder neck dysfunction, and polyuria. Here nephrology role is more important, and it is extremely difficult to treat this incontinence in posterior urethral wall. There may be acquired nephrogenic diabetes insipidus. So the moment we get a history of incontinence, we must find out whether it is really incontinence or whether it is just urgency or it is frequency, because with a high volume there may be frequency with a limited bladder capacity. Wall bladder, a detailed description of wall bladder and understanding is very important. Majority of the bladders, posterior bladders, can enter into the wall bladder. That may be their natural history. So one third of the bladders to close to adolescence start showing deterioration again. So initially we do follow them up very frequently in first couple of years, then the follow frequency goes down, but as they enter in adolescence, again we have to be more vigilant in following the children for the multiple reasons. As they enter in adolescence, they become non-compliant for the medication. If you have put them on CIC, they become non-compliant for the CIC, and they start holding manures, they don't pass urine for longer time, and these multiple factors put together end up with formation of the wall bladder. Wall bladder, there are three types which are described by Craig Peters. It's supposed to start with the bladder hyperreflexia, which are thick bladder, overactive bladder, which as they end in decomposition forms the flaccid bladder, myogenic failure. And poor compliant bladders are the bladders where multiple infections have taken place and bladder becomes non-compliant. So this may be two stage, it may not be the stage, but these different patterns of bladder are seen in the posterior urethral wall, and each type has a different treatment management. So again, as I said, bladder dysfunction at puberty is very common, and we need to find out that. So, uh, clean intermittent catheterization, overnight drainage is the concept introduced by the Stephen Koff, which is very important. Overnight drainage gives rest to the bladder. There is unimpeded drainage from the upper tracts that gives chance of upper tract to recover or at least stop the deterioration, and that gives rest to the bladder so that bladder decompensation is also halted. Here this CIC and overnight drainage may be difficult as they have sensitive urethra where you can consider metrophylla. So again, treatment of gallbladder, we start with the medical management provided patients are in first three stages of CKD, which are reversible stage and younger. As they go to the stage 4 5 of CKD, there is hardly any time to try anticholinergics. We do put them on medication, but we need to aggravate our efforts, and here we have to think whether they require augmentation or other modalities can be done. So recently came into vogue is intravesical Botox. We tried to search the long-term outcome of Botox, how frequently Botox can be given, how many times you can give the Botox. Effect of Botox generally lasts for 6 to 9 months. After that, it starts fading away, and you need to again assess them. So repeat urodynamics after 6 months or 1 year, depending on the ultrasound picture and the history, becomes mandatory if you have given Botox. But yes, Botox will delay the augmentation cystoplasty in these children. Augmentation cystoplasty, many people call it as replacing one disease with other disease because augmentation has tremendous morbidities. So it may not benefit child who is going close to transplant. It poses another challenge by augmentation. So role of augmentation in posterior urethral wall is another topic of discussion as well as debate. You may want to do augmentation. Many people do augmentation for preventing CKD. They do as a last resort in gallbladder syndrome and before transplant. So now again, this indication is debated. If child is going into CKD5, is very close to transplantation, whether augmentation should be done before transplant or transplant, both have their own problems and benefits. Because if you have augmented and want to do the renal transplantation becomes very difficult, and there is a chance that you can injure the vascular pedicle of augmentation. So augmentation is also at the jeopardy. And second thing is, as you give the immunosuppression, there may be fulminant episodes of urinary tract infection. So recently, Dr. Pipi Saleh has written a review article, again, that is still in press, I think, but available on the net, that is published in 2025, which says that generally, if you have to do augmentation should be done after renal transplantation, not before renal transplantation. Until the time of transplantation, the role of augmentation can be taken by the repeated Botox. For in our institute, we are transplanting children even with the unstable bladder, and to makeshift, we are putting Mickey button for the continuous suprapubic drainage or CIC, and putting them on CIC and overnight drainage. 1 year after the transplant, once they are stabilized, you can reassess if there is a need of augmentation, because there are multiple reports which says that bladder behavior changes after the transplantation, and for unknown reasons bladder is showing better patterns after the transplant, so augmentation can be delayed. Now, role of renal transplantation in posterior urethral walls. Again, as long as bladder is not stabilized, outcome of renal transplantation is going to be guarded. But if we are able to stabilize the bladder, transplant will have equivalent output. Um, there are on long term follow up, fertility is compromised in this patient. If I have some more time to talk, there are multiple things we can talk about. Otherwise, we stop now, and if we have any questions, we can discuss that.
Thank you so much, ma'am, for such informative lecture. I think you have covered all the aspects of PUV. I would like the audience to ask if there are any questions that they would like to discuss with ma'am. The mic is open for the audience. Any expert opinion and comment? I would request Dr. Oak sir to kindly say 2 words.
Yeah, first of all, I would like to congratulate Pradnya. Pradnya has been my student, and therefore today, in the morning academic session, when you told me that she is going to deliver a lecture, I decided to attend. I think she has done a stupendous job here. It's not easy to cover posterior urethral walls, and as she rightly said, wall bladder itself can be a different topic. Lasers in posterior urethral walls. I don't know whether Pradnya touched base on that, but that could be because Delhi and few other centers have been doing that. And
Yes.
so multiple aspects of this topic will keep on bothering you, will keep on touching your exam sites. You can get explain in brief, short notes, a detailed question of 20 or 25 marks. There will be X-rays of VCUG and scans, which will be put up in the practical examinations. And in the ward round, there will be cases. Vasacostomy, ureterostomies will be kept as short cases. And therefore, in short, you cannot escape. Now, the set of slides that Pradnya has presented today, I would suggest all the postgraduates to have a copy of them. If it's an IAPS repository, you may decide as per your policy. Because on the day prior to your examination or on the day prior to your practical examination, if you can rapidly go through them, she has practically covered every aspect of the topic and the answers that are expected. She has been very right of quoting Dr. Mohan Abram. When I was a registrar, when I was a young lecturer, Dr. Mohan Abram put up his Volvotome. And I am very happy that Indian contributions, as I always say in every clinic to my postgraduates, must be remembered and must be respected and quoted. And that was the contribution from Dr. Abram. PUVs will come to you in your practice and there will be multitude of presentations. I don't know, but whether Pradnya touched base on urinary ascites, because that also can be one of the rare presentations of PU walls when they end up into a small perforation. Augmentation cystoplasty, when I completed my MCH and lecturer's job and went to Liverpool for a brief spell, I learned augmentation cystoplasty from Mr. Rickwood and was feeling that this is going to be a good answer. So did do significant numbers and only to find that some of them leaked in the immediate post-op period. We had to redo them. There was an issue of mucus coming in the bladder and the blocking. Then came the era of diversions of mitrophenof, use of an appendix, catheterizable conduits. And PU walls, I still feel hasn't really got an answer. Injection of Botox, I have no personal experience, but seems to be a new idea. I don't know if Vadia group has done that or if any other group has done it. But that could be one of the mechanisms of taking care of immediate spasms and the hypercontractile stage of the urinary bladder. So I would not stretch the clinic long, but I was very happy. First of all, I compliment Alish and the entire Indian team of IPS. We at our departmental level have already started this activity on every Wednesday night. You are free to join, and we can invite multiple other people in this fora. And it poses also a very happy moment on an old man like me that I'm still in touch with the faculty and see the brilliant work done by my students. So congratulations, Pradnya. Congratulations, Shalis. And I'm very happy. Thank you.
Thank you so much, sir. I would like to request Dr. Sumitra Biswas, sir, to please say 2 words before we end the session. Sir, could you please unmute yourself?
Yes. Very comprehensive academic lesson by Dr. Pradnya. It is a marvelous job to complete all the aspects of PUV. It needs probably more than one session, but she has nicely done it with one. Thank you, Pradnya. Thank you all.
Thank you so much, sir. Ma'am, you have one question in the chat box. Someone has asked how to use Mickey button for valve bladder. Ma'am, could you please enlighten us on that?
Mickey button is temporary measure where you don't want to do CIC. So first we do the suprapubic cystostomy, and once you go beyond smallest size Mickey button is 12 size. So we insert the Mickey button and keep it closed because you can close it and open and attach the tube to drain the urine. So I think this idea has come from CMC Vellore. As far as I remember, I heard them in one of the SPUCON conference, and we have started doing that, especially for the transplant children, especially when we are getting cadaveric organ. So they get the organ, but bladder is not ready. So there we are doing putting picky button so that it is easy to drain. You can avoid periurethral catheterization because many a times it is not even easy to catheterize. Sensitive urethra plus sometimes they have stricture, sometimes catheter doesn't go in bladder. So Mickey button drains the bladder reasonably easy. So it is exactly at the position of the suprapubic catheter. You just remove the suprapubic and put in a Mickey button there.
Thank you so much, ma'am. Thank you for this enlightening session. Thank you for being, and thank you everyone for the session. With this, I end the session. Thank you so much.
Thank you so much.